It is preparing to live stream the meeting.
I'm
You all
dealing with
can't
some
see this.
allergies, so I'm sipping tea to keep me from.
Mute this. All right, so I won't get that feedback. So we are now live streaming, and I always cut this part when I edit, so no worries on that. Now I just need to find you guys on the Zoom. Got it. You all can still hear me, right?
Yes.
Okay, all right, and I am now going to hit record. Once I find the buttons, there we go. Record in the cloud. Okay, and we'll make that. All right. We will start in just a moment. Everyone looks fantastic. Now, Rosalind, anytime you want to go off video, you can. You're absolutely perfectly okay to stay if you would like, but I will also be off video whenever the conversation starts with Kelsey and Brown.
I will go off today. I've had 2 days of being a starer. So
You're a star every day, Rosalind Moffitt.
yeah, one of those students used to say, "You're a starer." I said, "Oh, okay." I've had 2 days of that, so I'm good.
Wonderful, wonderful. Well, it is 11 o'clock, and so we are gonna get started. All right. Okay, well, welcome everyone to our third day of Advocacy Week. We have had an amazing week. We started off the week with our Equity in Education, followed by our Equity in Housing segment. And today we are happy to have you with us in talking about our Equity in Health. So with Dr. Kelsey Walker-Pope and Dr. Brown Henderson Hatch, they are going to be talking to you about the inequities in healthcare, along with some diversity, equity, and inclusion and how that's impacting health and healthcare, especially in the state of North Carolina. Dr. Kelsey Walker-Pope started her career in health at the very young age of 14 as a peer health educator for teens against AIDS, which is just phenomenal work to know even what you want to do at the age of 14. Followed by that, Dr. Kelsey, as we so fondly call her at the Research Policy Impact Center, she followed up with some employment with the Public Health Educators segment with the North Carolina Department of Health and Human Services. So she was a public health educator there, and then followed up with some work with the U.S. Department of Veteran Affairs, followed by her work with St. Augustine's University, which is where I know her from because we were both at St. Augustine's University, I think about the same time. At St. Augustine's University, she was an assistant professor as well as department chair over the Department of Health and Exercise Science. But now we have acquired Dr. Kelsey's expertise at the Research Policy and Impact Center with the National Institute of Minority Economic Development. And she's been with us for quite some time now as our Director of Health Equity Initiatives. And we are so happy to have her. She's doing a phenomenal job and just excited about having her on this call and segment for Advocacy Week this week. Joining her is Dr. Brown Henderson Hatch. He is an inclusive engagement professional with experience in diversity, equity, and inclusion, as well as workforce development and educational programming. He has worked in several leadership roles within educational and government settings, and currently serves as the director of the Office of Diversity, Equity, and Inclusion for the North Carolina Department of Health and Human Services. In this role, he leads initiatives for creating and sustaining a strong and inclusive work environment for thousands of employees across the state of North Carolina. focusing primarily on the efforts of statewide health equity. His past professional experiences include serving for community engagement at North Carolina A&T University. He most recently served as the executive director of Thrive High Point, a multi-million-dollar initiative to support minorities and women in entrepreneurship. Dr. Hatch is an active in several community and civic organizations, to include serving on boards of directors for the North Carolina Conference on Community and Justice, Trailblazers Impact Foundation, and Motivational Foundation Incorporated, as well as the International Society of Furniture Designers. And we are so excited about having Dr. Brow Henderson Hatch, as we fondly call him, Dr. Brow, with us today. So I'm going to let Dr. Kelsey and Dr. Brow entertain you, inform you, in their wisdom and knowledge and their area of expertise today. So Dr. Kelsey, take it away.
Thank you so much, Talitha, for the warm introduction. And thank you so much, Dr. Brown, for being with us today. We're excited about our discussion as it relates to health equity, as well as diversity, equity, and inclusion. So I know Talitha just kind of briefly went over your background and your experience, but I want you to talk to us about your role currently with the Department of Health and Human Services and the department's key focus on the health and well-being of people in the communities that you all serve.
Well, first, thank you all for having me. I'm really excited to be engaging with you all and love the work that you all do in the Research Policy and Impact Center. North Carolina Department of Health and Human Services is an 18,000 plus organization that includes everything from physicians to nurses, public health educators, individuals who provide grant funding, really to make sure that the residents of North Carolina have access and support in reaching their highest level of health. And so when we talk about health equity and the portfolio I serve in, which is the health equity portfolio, our offices really are charged with making sure that both the internal and external factors that impact health equity, we're addressing them head on. And so with the Office of Diversity, Equity, and Inclusion, my office really is charged with making sure that, okay, we know that health equity is an issue. We know that we have thousands of employees who are on the front lines, handling programming, writing policy, procedure, practice. How do we make sure that they themselves, number one, feel a sense of belonging here at the department, and then number two, that they are well-versed and have the support they need in order to work with the diverse populations that are within North Carolina. And so when we have conversations on DEI, it's more than just, the definitions training and, how to be inclusive in the office, but really it is addressing all of the various cultural factors that impact health equity and inequity. And so a lot of the things that people face when it comes to harassment and discrimination in the workplace are some of the same root causes that create health inequities in the community and across our state and throughout our country. What I love about what we do is one of the values of North Carolina Department of Health and Human Services is a strong and inclusive workforce. And that means that we really want to make sure that our workforce recognizes what culture, what difference looks like, how it impacts how we work, but also the work that we do outside of the four walls of the North Carolina Department of Health and Human Services. I can't count the number of people that I meet on a regular basis who may work in health facilities in the eastern part of the state. They may run public health initiatives in the western part of the state, people from all over. And the question that continuously asked is, okay, how can you help us, recognize the impact of DEI and what does it all mean? And one of the things my office really is charged with is making it approachable, helping people to understand DEI is not a scary thing. It is not a checkbox training. We in my office say that DEI is everyone's job every day. And that's because you do not work or serve or help anybody that is exactly like you. Regardless of, you may look alike, you may have the same racial background, you may share the same gender identity, you may share the same geographical location, but at the end of the day, everyone you work with, everyone you serve is different than you are, and you're different than who they are. And so we want to make sure that we are having those conversations and helping people have the skills, the knowledge, and the awareness to maximize that interaction and to really help tackle those inequities that impact people's health experiences.
Excellent. Thank you. One of the things that rises to the top for me in terms of your response is how DHHS is or strives to be intentional about DEI even within the workforce. It's important for those who are working within the workforce to be able to understand and recognize the importance of DEI, even alongside their colleagues. And you bring up a great point that it is important to make it approachable, and we don't want populations of people to feel any sense of blame or just a level of we just want them to be comfortable in being able to discuss DEI, what that means for, and a lot of times, their end user, their clients, the people they serve. And so that's excellent that DHHS is intentional about making sure that DEI is woven throughout the workforce. Could you talk a little bit about DEI, diversity, equity, inclusion, and how that may look different from health equity? Or are there some things that kind of are woven together? So if you can talk a little bit about the differences from your perspective about DEI versus health.
Absolutely. And Dr. Kelsey, I get that question all the time. People ask, how does it all work together? And so the health equity portfolio, where I serve in NCDHHS, consists of 3 offices. The Office of Rural Health, which is one of the, I believe is the oldest rural health office in the country. They're getting ready to celebrate 50 years. The Office of Health Equity and the Office of Diversity, Equity, and Inclusion. And so people often ask, well, how does that all work together? What is that? They seem like 3 different things. And while they are 3 distinct different efforts and initiatives, they all address the same root cause of difference, discrimination, access, and opportunity. And so we know that rural health is important because geographical location is a huge factor in how people are able to access quality care and the way health is promoted and those kind of factors. Health equity really is that intentional effort to say, we want people to achieve their highest level of health, and we want to make sure we are addressing the barriers, the policies, the procedures, the funding infrastructures that hold people back from being able to achieve that highest level of health. And so that includes, COVID really kind of pushed us into this concept of health equity. I mean, if you think about it, yes, health equity was a conversation in 2019, but 2020 was that reminder that a global pandemic that was felt in every corner of our world literally showed us that health equity is a big thing, or even more so, health inequity. Number one, people being able to access the information to learn about vaccines, people, partnering with community organizations that people trusted in their communities to say, hey, the vaccine is a good option you need to check out. Testing, knowledge about transmission, accessing healthcare if you were testing positive and needed some type of medical intervention. All those things are a perfect example of health equity. The other thing about it is, with health equity, so many people are doing the work without the title. And so I say, in my opinion, with NCDHHS, all thousands of us are all health equity practitioners, because at the end of the day, we want to make sure that the services and the care that we provide to the citizens of North Carolina, we're addressing the specific needs that people have when it comes to accessing healthcare. And then the Office of DEI. Our office, number one, has intentional conversations about the factors that create health inequity. So socializing concepts of what a strong and inclusive workforce looks like internally and externally. If you're working with broad populations of all demographics, but you're unaware of the various factors and facets that impact identity, it's going to be a little difficult. The other part of it is my office also wants to make sure that we are preparing the workforce to work with the actual population. We know that there are hundreds of thousands of people who receive benefits from Medicaid, who are beneficiaries of other programming and activities. We work very closely with the faith leaders in various communities. Well, all that stuff is great, but we also have to make sure we have skilled, aware, and knowledgeable staff to actually go do that work. And so my office focuses on, we look at the demographics of, our workforce. We look at disparate impact. Is there any type of impact in the workforce pipelining? My office also supports our HBCU MSI internship program, where we're saying, hey, how do we identify the next generation of diverse public health officials and administrators and employees? And so all it kind of comes together to say, we want to tackle inequity. And so my office tackles inequity from the standpoint of, in my opinion, the knowledge, the skills, the awareness, and the conversations. Health equity is that boots on the ground strategy initiative to say all these social determinants that impact my ability to access healthcare. And not only access healthcare, but access quality healthcare, access quality healthcare that I am able to receive that is culturally competent and that is using professionals who recognize cultural humility in how they engage with me. All those parts go into the equation. I think I talked a lot about it because I love this work. But I think it's really amazing when people realize that so much of our disconnection is off communication and awareness. And a good example that I often use is if you are a public health official and you're working with a population, there's a population of people who all have different home remedies, right? And so I know one of the home remedies in my household was if your stomach hurt, you go drink some ginger ale, right? Ginger ale was that magical elixir,
And
right?
lay down.
And lay down, exactly, right? And so, if it were really bad, I would go to the doctor. If it were pervasive, I would go to the hospital. But think about the populations of people who decide, I'm not going to go to the doctor right now because I'm going to drink this ginger ale and lay down. Now, when I get to the hospital or the healthcare facility and I tell my medical team that's working with me, well, they will say, well, Dr. Hatch, how long have you been presenting with these symptoms? And I was like, it's been about 2 days. I drank ginger ale, laid down. Now, imagine not recognizing that in my mind and in my culture or my household, that's a viable decision. Imagine being judged for that and being treated accordingly. Well, I'm not going to feel comfortable in the medical team. I'm either going to feel like I'm not receiving quality care or I'm not going to take seriously the care I'm being given, all because of the lack of understanding of cultural difference. And so it's those type of conversations that we like to have because your understanding and awareness and openness impacts how you receive care and also how care is given. And so those are the things, that's the connection between DEI and health equity. From my perspective.
Thank you so much. And you've hit the nail on the head in so many different ways. I would like to touch on the preparation of the workforce in terms of, I know you mentioned HBCUs, historically Black colleges and universities. And as you mentioned, COVID just really blew the top off in terms of how we look at health inequities, populations that those exist within. And you mentioned the Office of Rural Health. And I know that they've had some work around community health workers and making sure that they are trained appropriately But one of the things that they have also tried to infuse as well is are the social determinants of health. And so it's just wonderful to see how one word you just mentioned was openness, and how people are, or the workforce is becoming a little bit more open to talking about things that they may not have been as comfortable with maybe 5 or 10 years ago. Also with COVID, we noticed that there was a lot more funding that was brought down from the federal government to communities to address these barriers, these structural barriers that people and populations may experience. I know previously when with my work at St. Augustine's University, we had a couple of grants that worked around COVID-19 and being intentional about reaching disparate populations. And one of the great things about that was not only were we able to connect with members of the community, but we were also able to utilize our students, our public health students. And so that was giving them some of the boots on the ground training, the education, the skill set, so that they can be a part of that pipeline of public health work, public health professionals as well. So that's a great point that you mentioned. So in terms of DEI, diversity, equity, inclusion, how do the factors of DEI affect health and healthcare from your perspective?
I think it's pretty prismatic. And so I think one of those things is, let's look at it first from the business model perspective. We know that happier employees tend to be more committed to work, more flexible in the ebbs and flows of what it means to be an employee anywhere, right? It's all levels, all spaces can be, this up and down. But really, I think we never can diminish the concept of belonging. And so that intentional safety in knowing that when I come to work and I bring my full self to work, my differences are used as strengths and not weaknesses. My commitment to the work we do is recognized, and there are activities and initiatives to support and say, hey, thank you, we appreciate what you do. And so, especially in healthcare, for all of us who work in, and while I'm not a healthcare professional, all of us, work in these front-facing, impact kind of oriented spaces, right? And many of us, are doing it because we love helping people. And so that's not necessarily easy work. And so when you come back to your offices and your workspaces, we really don't want people having to feel like they're being harassed or discriminated against because of who they are. You don't want people feeling like that, their identities and roles outside of just employee are being, undervalued. So if you can feel like you belong and I'm a part of a team and the work I do is appreciated, I'm much more likely to come to work when scheduled. I'm much more likely to put all of my energy into work when I'm at work. I'm also able to have work-life balance. And so the statistics are out there that show and prove that all these things impact an employee who has more longevity, more commitment, and also it really helps to whatever output that employee is doing. So when it comes to healthcare, if you're healthcare practitioners, we know so many of them are overworked, underpaid, and we recognize that. And while those various idiosyncrasies are being worked out, navigated the way they are, but really, it doesn't cost much to have people feel safe at work. Conversation is free. Inclusion is free. Belonging does not cost a lot. So if those individuals can feel valued, of course, they're going to be, much more aware and much more supportive in the work they do as frontline healthcare professionals. But then also with healthcare, recognizing that all the various identities we exist in impact our healthcare experience. I have 2 parents who are pharmacists. So naturally, when I go to the doctor and I'm diagnosed with something or I'm given a medication, I grew up in a household with 2 pharmacists. So I'm aware that PRN is as needed. I understand, because I grew up in that household. But what about the person who didn't? the person who is kind of talked to and they're like, huh, what? And so if the person does not feel like they've received information that they don't fully understand and like, whoa, and the space is not safe enough for them to get the resources to kind of have it explained to them, well, when they go home, what happens? You don't take the medication at the right time. You forget to eat with it. So you're sick on your stomach and you discontinue taking the medication because you say, I'm sick on my stomach. Well, when you go back to the healthcare team and they don't see any change and you tell them, well, I stopped taking my medicine, because that interaction right there is valuable. And so we make these assumptions and we also assume over and under that all impacts how we receive information and how we perceive it. The other part of that is if people who are frontline facing are aware of cultural difference. And when I say cultural, I often love the word culture because culture encompasses everything. It encompasses race, religion, gender, how we dress, the food we eat, the music we listen to, the things we heard our grandmamas tell us when we were 5 years old that we remember at 45 years old. All those things are encompassed. And while nobody, including myself as a DEI professional, or you, or Talitha, or Rosalind, or anyone else, none of us are fully aware of everything. Our hope with DEI and cultural humility is, while I'm not aware of everything, I'm taking the time to step back and listen to what you tell me. I'm taking the time to sit back and understand when you say something to me. I now recognize that I need to be aware of that in order to see you and treat you and engage with you appropriately. So using my example again, now that I understand that you drink ginger ale when your stomach is upset. So now I'm not going to come harshly or judge you because your blood sugar's up because you've been drinking all this ginger ale. I'm also understanding that, hey, I probably need to better explain to you how this medicine can make your stomach hurt if you don't eat with it. Or recognizing that if there's something in the instructions you don't understand, give us a call. Let us know. It doesn't take much more time, but it creates that safe space because I understand that these things are culturally impacted. And so when we have those type of conversations, the DEI world kind of comes into it. And the other thing about DEI is, we're really starting to socialize not only belonging, but accessibility, especially within the workplace, but even externally, where accessibility is that intentional, awareness and effort to say, we realize that language accessibility is a big thing. Accessibility when it comes to people who may be differently able. When it comes to various intellectual developmental disabilities. All those things when it comes to accessibility are part of the inclusion and the belonging piece. And so we also have to recognize that. And then at the end of the day, and I know I can talk about this all day, Dr. Kelsey, so stop me when I need to, but at the end of the day, we also have to recognize this thing called intersectionality. That one identity, and may not be the only one I'm considering, when it comes to my health choices, when it comes to my various social determinants to health, the education, the residential location, my access to technology, all those things impacting how I realize and how I engage and how I evolve as someone who is thinking about my healthcare on another level. And so the intersectionality piece is huge because when we go out and work with external populations, we have to realize that they're just like us. Their race, their gender, their educational attainment, their geographical location, their values all come together and have them existing the way they exist and live. And the same thing for us when we come to work. When someone says something offensive to us at work, it may not just offend one identity, it may offend multiple identities. And we have to recognize that intersectionality is a big piece. And so I think that, especially in the times we're in now, when we're having more conversations on equity and diversity, we really must realize that that intersectionality piece and culture piece is primary, because regardless of your racial identity, regardless of gender or sexual orientation or any of those pieces, we're all multifaceted individuals. And the more we can recognize that just like I'm coming to the table with 9 identities I want affirmed and respected, the people I'm working with are coming with just as many, if not more. And the awareness of that, I feel like, really helps us to move the needle in a positive direction. And we recognize that I can go train you for an hour and a half. You might not come out the room as the DEI champion, right? We understand that. I could go sit in a Portuguese class for an hour and a half and may only give you one word, right? But what comes from intentional engagement, education, and guidance is recognizing that this thing exists. It's not necessarily saying that you have to be a brilliant, inclusive professional who knows all the differences, and I can tell you what all the different acronyms mean. What we're asking people to do through this type of engagement, this type of training, these type of conversations is to, number one, be aware of difference, be aware that difference plays a role in how we receive and give information, care, and how we work, and also recognize that the things we do and the things we say are often based on our biases. We have to check our biases and recognize that, the things we put out impact people's experiences. Be it your experience sitting in a meeting, be it your experience in a healthcare practitioner's office, be it your experience at a vaccination clinic, be it your experience in a maternal health workshop, all those things impact it. And that's the kind of conversations we're looking to have and we work to do through our office and our portfolio.
Excellent, excellent. And you just brought up so many things that we must consider. And as you were talking, it made me, a couple of words came to mind: respect for other cultures, cultural beliefs. And as you mentioned, even traditions play a role. That might be a reason why we may, even when we think about New Year's, our dinner, we prepare.
Yep.
That's the part of tradition. Now, sometimes it may not be prepared in the most healthy way, but as someone who is on the front line and working with people to make maybe different choices, we have to be mindful that there is a reason why people do the things that they do. The other word that came to mind is also trust. When people, sometimes I remember early in my public health career, I worked with churches and I helped them with their health ministries. And I recall, and I worked in a county that was just one county over from Wake County. But I remember one of the church members saying, "You're not from here, are you?" And so even though we looked alike, there are still some differences within that population that I was working with. And so, building trust is so important because we can't automatically assume that people are going to let us in.
Right.
And especially if we are delivering healthcare in some way, shape, or form, or if we're working to educate them, we have to be mindful that we have to build trust. We have
Absolutely.
to have the respect with the populations that we encounter.
Absolutely. And I think if I can interject, I think this is where the community engagement piece is so significant. So community engagement really, suggests that we, number one, identify those individuals who are kind of like the hubs of information and resources in a various community, and that we work with those hubs, but also that we recognize, the community context of a lot of the work we do. And so kind of using the example you use is a lot of times, and we see this all the time, right? And there's an effort in a community. You send the person who looks like that person of the community, send them in the community, and you think automatically, just like I dream a genie, everything's gonna work out well. Well, not so much. Community context is huge. And once again, the intersectionality. Just because I have one or two identities that look like or act like yours does not mean the other ones that also play a role in how you engage are aligned with mine. And so when we recognize it in community engagement, we don't just say, we sit in these boardrooms and come up with all these great, we're going to do a program on this. And we wrote the grant, we got the money. And Dr. Kelsey, how many times do people go in the community and it falls flat? No one uses the resources. You're trying to figure out if you can get some no-cost extensions. You're trying to figure out how you can, because for whatever reason it fell flat. Well, maybe the reason it fell flat is because we never took the time to evaluate and assess how people want to receive what we're giving. A lot of times, as in public health and community engagement and business, all these various spaces, we know that there are disparities, and we want to make sure that people are getting access to things that help them get out of that, knock down those barriers. But we have to be intentional with saying, how are people ready to move to another space? How are they ready to receive the information? Have we considered who is facilitating this information? Is it coming from, as you said, a trusted resource of who has historically been able to provide that information? All those pieces go into it. And so when we have conversations about health equity and the various social determinants and the various concepts of belonging and DEI, when we finally get outside to hit the start button, before we hit start, have we had a conversation about who is our advocate? I'm big on the 3 A's: advocate, ambassadors, and advisors. Those 3 populations are huge, and they're not always the ones within the 4 walls of our conference rooms. They're often in the community. And so when we want to authentically speak to people and authentically connect to what they need and who they are, have we done our research? Have we done our activity? Have we done any type of assessment to say, now that we have some good understanding about everything and identity and the history of the community and what has worked, what hasn't worked, now we can actually hit that start button. Because sometimes it's a one and done. You don't give a one shot, and you don't want to waste that.
That's a great point. And when you talked about grants, how many times have agencies or organizations secured grant dollars, performed the work, and gotten the information they need, and then that's it?
That's it. Yep.
Many times communities have felt like they've been used just for information purposes without that agency or that entity coming back to say, hey, as a result of our collaboration together, this is what we've been able to accomplish. But, we also see that there's some additional gaps, and we want to continue our relationship. So that's also so important as well, in terms of the trust and recognizing, I love those 3 A's that you mentioned. So recognizing the key people, those stakeholders in the community. So excellent point. When we think about DEI, can you talk a little bit about why the training, and you have touched on this as well, but why the training is so important to those working with communities, even before they are employed? Why is that training so critical to those members of the community?
Well, I think, I love education. I think it is a tool that not only informs, but it liberates, it affirms, it acknowledges. And we never can underestimate the value of education. So it doesn't always have to be a formal degree. It doesn't always have to be a certificate program. I'm an advocate for both the formal and informal educational experiences that prepare us to go outside and work with different people. And training really is that educational opportunity. And sometimes we say training because education scares people sometimes, like, oh my gosh, I'm going to take a test, I have to do homework. No. At the core, training is an educational endeavor where there's some mechanism that is transmitting knowledge that is intentionally being transmitted to help move your knowledge base in another direction or to another level. The first thing in our training is, once again, the assessment piece and the outcome piece. So when we say we're training people for DEI, whenever I meet with a group, I say, well, what is your outcome? What are you hoping to get from this? Well, I'm hoping that people will be able to do X, Y, and Z. Okay, that's great. But what does it take for people to get to that space? And so the first thing when we're having these conversations that we love to have is let's talk about what the definition of diversity is. What's the definition of equity? Let's talk about the definition of inclusion and belonging. And then let's also put it in very realistic terms that people can absorb and see how their work impacts the overall work. And there are all these different experiences, different examples. Sometimes people say, inclusion is being, asked to come to the dance and being asked to dance when you get there, and all those various examples. But at the core, really making sure that people have the perspective and the baseline knowledge, I think is huge. The other value to training is the more familiar people become with the concepts, the more likely you are to regurgitate it and to personify it in your various spaces. And it's not always necessarily saying we're going to give you a checklist and every interaction you got to check every box to make sure you're being equitable and you're being inclusive, but it's also to kind of get your mind moving and to get the light bulb moments that may occur that realize that this thing is not just a workshop or a training, but it's actually something to improve how you work, but also how you're able to connect and you yourself are able to belong in these spaces. And so even before you become an employee or you work on a specific team, it is really helpful to be able to engage in some type of training or learning opportunity where you learn what DEI is all about. Especially within the health equity stance, I think that even if it's just a 10 or 15 minute knowledge, nugget, those opportunities are great. One of the things I love about where we are now with DEI is you can Google. You can Google health equity, you can Google accessibility and belonging and get some pretty good stuff off Google. I'm not going to say everything's going to be the most poetic, poignant thing in the world, but you can get some basic information. And also, one of the things my office says is we make trainings available. We'll come sit down with your council. We'll come sit down with your leadership team. We'll come sit down when you have your conferences or your staff and say, hey, we'll just, provide some baseline knowledge about what is DEI. How does it impact health equity? And I think that the beautiful part is people are starting to realize that just like our identities are intersectioned, this knowledge and health equity and DEI are also intersectioned, and they all kind of roll off each other. They all kind of impact the other. So the training part is imperative. And that can look like anything. It does not have to look like a 3-hour seminar that costs $1,000. It doesn't have to look like that. It can be a baseline training. It can be for 5 people. It can be for 5,000. It doesn't have to be a very complicated concept, but at the end of the day, it should do a couple things. It should answer the question of what are you hoping people will walk away with? And number 2, it should be able to connect what they do day to day to the knowledge being transmitted in that training opportunity, in that educational experience.
Great points. And it's never a one-shot deal. It's continuous over time, just to make sure that we are that DEI is woven into the work that we do on a daily basis. So excellent point there in terms of the training and why that is important. Let's kind of shift gears just a little bit and kind of talk about the social determinants of health and how DEI and health equity shows up within the social determinants of health. So in looking at the social determinants of health and how they affect people in the communities that you serve, how does DEI show up in terms of access to quality food, access to healthcare? You mentioned that as well. Transportation issues. How does DEI and health equity show up in these social determinants of health?
Well, I think they show up everywhere. And so I will even, we can first talk about food. Food is absolute textbook identifier of culture, of identity, of values and beliefs. All that is, food is a big part of that. And then we also know that food insecurity is a major thing. And so where DEI comes in with that is owning and recognizing and acknowledging how people engage in their food experiences is connected to culture. And it is an expression of culture. And I think that's the part that we often, I'm not gonna say we forget, but we recognize that the disparities in food insecurity and access to healthy, fresh, foods are drawn across some demographical lines of diversity, race, economic status, which is another social determinant of health, educational attainment. It's kind of interesting. It all kind of aligns, and it all is lined up there. Another thing is housing. Individuals who have more economic stability and who are in homes that they own or in affordable housing that is safe and secure. But also, a lot of times people live in housing that has mold issues, asbestos, living in allergens and all these other pieces. But once again, the lines for that are drawn across what? Educational attainment, economic stability, all those pieces. Well, the thing about that is, just using the examples of housing and food, both of those impact your health status. If someone is unable to access healthy, fresh foods, they're typically going to be eating more, hyper processed, things that are not fresh. And that ultimately, textbook, not Brown, but textbook impact health, right? Also for housing, the stress of not being able to have safe housing on a repeated every night, not being able to go to the same home or having that stability impacts stress levels, which impacts health. Living somewhere that has unhealthy water and air and allergens impacts health. And so, but once again, with all those being drawn clearly across racial and economic divides and ethnicity, we know that, it's all kind of brought together. The other thing about this is really owning and recognizing that if these populations, if these demographics are being impacted by these various social determinants of health, and it's all impacting, how they're able to, number one, needing more medical intervention. That's the first part. Number two, being able, because they need more medical intervention, are you able to access more medical intervention? Are you able to fully reap the rewards of said medical intervention? But then also recognizing that how we engage with people impacts their willingness to kind of move forward with that. And so there are a lot of people who are hesitant of healthcare because of how they're treated. There are a lot of people who don't receive information, it's not facilitated to them in a caring and kind manner. It is, well, you need to eat better. You need to lose weight. You need to eat better. Well, I live 5 miles away from a grocery store. Well, get in your car and go to the grocery store. I don't have a car. Well, have someone take you. I live in public housing on a public transit route that takes me an hour or so to get to and I work second shift. And all those various pieces impact that. Also, I feel that where the community engagement piece comes in is, are we trying to necessarily link the various interventions and pieces that kind of all play a role in this? And also, are they aware of the various facets of diversity, equity, and inclusion? And so when we have these conversations on social determinants of health and how it impacts, of course, healthcare, but also health equity, are we having conversations on, do we really understand the intersectionality and how all these things are compounded and how it's not a one size fits most approach? And so unfortunately, it takes a lot of time and at times money to address these things. But a lot of it starts with just the awareness. You can't fix what you don't know about. If I tell you the water's not coming out of my spigot in the kitchen, and I call a plumber, if the plumber never looks at my water line from the street, never asks me questions about what am I seeing come out of the faucet, ask me when the last time I've used the faucet, have you ever had a drip? Have you ever had a leak? Have you ever had bad water pressure? If I call a plumber and the only thing they do is say, yep, faucet, no water coming out, we got to fix that one faucet, you never really addressed all the various pieces. And to me, that's the quintessential experience we have with health equity and the social determinants to health. People who are committed to helping the lack of water flow, committed to fixing, but also not aware of all the various pieces that may be impacting why the water's not coming in, and how I feel about not having my water come in, and how I feel about not being asked about my experience, or not being asked about, all those various pieces. All that coming together, and where DEI plays the role is DEI's job is to teach people that all those other pieces impact why the water's not coming out. So whereas health equity also goes in and addresses specifically those issues, we teach that background knowledge of why these type of discriminatory things are occurring, why the difference matters, and how it all comes together.
Excellent.
Yes.
I couldn't hold back any longer. I had to jump into this conversation. This is a phenomenal conversation. You all are on fire on YouTube. You are on fire on Zoom. The knowledge and wisdom that is bleeding through this conversation is, I almost want to make Advocacy Week a part 2 in this conversation, because you all are just spitting out the knowledge. So with all that being said, I'm just going to jump in here and ask questions. I know that you were just talking about the social determinants and all that. The analogy with the pipe was phenomenal as well. Do you all have through the State Department, other programs that you are working with in collaboration with any local businesses or universities that help with improving these types of social determinant conditions? Is there anything like that involved? And then previously in the conversation, I heard you talk about internships. And so through that program, are you working with any specific universities, HBCUs specifically, or colleges in that program as well? Just trying to help people who are listening know where they can go to become involved.
There are, I'm gonna answer it like maybe in 3 different ways. The first is my office, the other offices within the portfolio, and all the various divisions throughout NCDHHS absolutely work with external universities and have those conversations. UNC Chapel Hill plays a significant role in a lot of the conversations we have when it comes to health equity in the Medicaid space. And where it comes to conversations, having fellows who are public health fellows come work with us. Also, one of the things that I love that we've recently done is our health equity office has led the way, and we've engaged with them, is working with Black faith-based leaders, where working with those community organizations, be it churches, be it nonprofits, but all people in that faith-based space, to kind of make that next intentional step, but also to make it a mutually beneficial relationship. So whereas we're coming to them for community guidance, but they're coming to us also for best practice and knowledge as well. Then there is the HBCU MSI internship program, which I'm a huge advocate for, not only as an HBCU graduate and former administrator, but also as a DEI professional who often looks at the pipelining of people to do this work. And so we know that you have to have not only a strong and inclusive workforce, but a robust and diverse workforce to work with the robust and diverse population that is North Carolina.
That's right.
And you want to make sure that representation matters. We know that there are absolute health benefits to the patient-physician concordance. where if I have a physician who may share my racial or ethnic identity, my health outcomes tend to be a little bit better. So those type of conversations. And so making sure we're pipelining in. And I always say, you never know who the junior biology student at an HBCU who interns with us, in 10 years, they may be the person who's over your nursing staff at one of the hospitals. They may be the head of clinical psychiatry at your state health facility. They may be your chief medical officer. You do not know. But imagine what that type of impact and exposure does. Also, look at the benefit that does to North Carolina. Now you are saying we intentionally recognize difference, but we're also making sure we're creating equitable inroads to these type of career paths and to this type of work. The other thing of that is, in my office is absolutely, I'm a huge fan of engagement. Talitha, you know, I can talk all day, but I do, but I do love.
We love every minute of it. You're hitting
think,
all the points.
I think there's something very authentic and beautiful that comes from the connection, the collaboration, and the convening of like-minded individuals and organizations. And so my office, we engage across the state with other DEI leads. We meet with DEI leads from chambers of commerce, from universities. We have these conversations. I recently even met with a DEI lead from IBM the other day, because so many of us are doing this work that does connect. Even if our industries and everything don't align directly, the work is very consistent and we're all having similar experiences. And so in order for us to move this needle forward, I feel that we have to be in good relationship with the university system. We have to be in good relationship with the workforce development and community college system. We must recognize where people socialize. So we need to be in good relationship with community organizations and faith-based organizations. We also have to be in good relationship with K through 12 systems, because a lot of health is learned those early stages in the K through 12 system. How I learn to value my body and my health often takes place for many children at an early age in our public school system. And so all these pieces play a role. And so the external engagement is an absolute yes. Working with universities and post-secondary educational institutions is an absolute yes. And then our desire to expound, our desire to grow, our desire to make that relationship even more dynamic and prismatic is also an absolute yes.
Phenomenal. I'm sorry, I just stepped right over you, Dr. Kelsey. Go right ahead and take over again.
Thank you for jumping in. That was a great question that you posed. DEI is everywhere. And, you know, it's just so important for no matter what, whether you are working in a health agency, like you said, education, it is absolutely everywhere. And it's so important that those who are in leadership roles recognize the need of DEI training. So along those lines, and I guess this may be our last question to wrap up with, what are some strategies that individuals can implement in the event that their organization does not have a DEI office, or that there needs to be some additional training?
Number one, you have to identify a champion, someone who's going to champion that cause. And I often say, even when I have gone in and worked with smaller organizations and smaller offices, if you've got a team of 10 people, you're probably not going to be able to have a DEI officer, right? Someone who that's their only job. But think about where the values and principles of difference exist, right? And so the reason I say DEI is everyone's job every day, because it really impacts everyone. Your HR officer should be aware of how discrimination and difference impacts where job postings are sent, who applies, how people are interviewed, how people are selected, the timeline for onboarding, all is impacted by DEI principles. When it comes to programmatic support, how we engage with external populations, and the programs we set up to really alleviate these barriers are all determined a lot by DEI practices. And so where you may not be able to create a DEI council or a DEI officer, you can say, well, we do a monthly team meeting. Hey, let's do a DEI moment. Let's do a pulse check to see how people feel. Do they feel like they belong in this workplace? Let's also take a moment to have maybe a once or twice a year hour training on what diversity, equity, inclusion looks like in the workplace. It does not have to be the most formal, but it has to be intentional. Without intentional, you really don't always have positive impact. The other part of this is inclusive leadership. A lot of the stuff I'm talking about and the conversations we're having start with leadership. And so one of the things I love about what we do at NCDHHS is we have about 29 diversity councils across our entire organization. Each diversity council is led by co-chairs who are part of the council, but each one of them has an executive sponsor. Someone who has said, I serve at a management supervisory leadership level, and I'm going to be the champion for this conversation in this office or this division. You have to have a champion. You also, I think, for inclusive leadership, the various principles on, listening to how people, what their experiences are, asking questions, caring about what they say, but also one of the topics I found really fascinating in this space is courageous vulnerability. As a leader, saying, I don't always understand everything. I'm not aware of everything. I didn't even know these things existed, but I'm making the commitment to say, number one, I didn't understand it. Number two, I see a void or a deficit with myself. But number three, I'm going to step in and say, let's learn this together. Let me acknowledge that identity and experience is impacting how the people I lead are showing up. And the work that they do is definitely impacted by this. And so to kind of circle back, I think that inclusive leadership is major, but leaders have to realize that they don't have to come up with a 5-year DEI strategic plan. They don't have to hire a DEI officer. You really can start where you are. And you can say to your team, be it 3 people or 3,000, hey, let's talk about identity. Let's talk about bringing your full self to work. And let's talk about making sure that we are creating a workplace that has a zero tolerance for harassment or discrimination of any kind, especially when it is applied or based due to one of the identities we're asking to come to work with and that we see as a strength and never a weakness.
Awesome. Awesome. Thank you so much. I love that term, courageous vulnerability. That's so important. I'm going to have to use that along with those 3 earlier as well. So we are so grateful for your knowledge and expertise that you shared with us today. Thank you so much for taking time out of your schedule to discuss this very important work. I could feel your excitement. And so we are glad to have a champion in you on the state level to represent this work and to make sure that it's infused throughout the counties in North Carolina. At this time, I'll turn it over to Talitha.
Absolutely. There's nothing for me to say. You all have opened and closed this session with your knowledge, your energy. I also was thinking to myself, Dr. Kelsey, you as well, and Dr. Brown, you both just have so much knowledge and wisdom, and we are grateful for that in your positions and taking the time to talk with us and our audience today. But also the energy that you bring makes other people want to get involved and be impactful or as impactful as a small amount of that you have and doing every day. So thank you for that. I'm pretty sure this will be listened to and watched over and over and over again to write down all the details that you've given to us today. And we are just so grateful for that. The feedback that we've gotten already has been phenomenal.
Awesome.
So watch out, Dr. Brown, Dr. Kelsey, we will be calling you again so, for this, because this was truly a great session. So thank you so much. Thank you, Rosalind Moffitt, for also helping us with getting this call together in the engagement that you had with us today. We are going to sign off, and thank you all again so much for being with us.
Thank you all. Appreciate it.
Thank you so much.
Bye.